Okay, I have 2 minutes after 10, so I'd like to welcome everyone to the Substance Use Response Working Group's Response Subcommittee. This is Terry Kearns for the record, and we will go ahead and get started. Crystal, if you can call the roll.
Happy to do that. Crystal Duarte for the record. Christine Payson.
Present.
Dr. Stephanie Woodard.
Present.
Dr. Terry Kearns.
Present.
Shayla Holmes.
Present.
And Gina Flores O'Toole. It looks like we don't have Gina, but we do have a quorum.
Great, thank you. If Gina happens to come in, if you can just let us know. Okay, to start out, I'd like to open it up to public comment. And I'll start just by saying that the statewide substance use response working group and its subcommittee may take items out of order, combine two or more, or remove any item from the agenda or delay discussion related to an item at any time. We're pleased to make reasonable accommodations for members of the public with disabilities who'd like to participate. And public comment will be received via Zoom by raising your hand or unmuting yourself. When asked for public comment shall be limited to 3 minutes per person. And this period is devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public unless the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. We'll pause just a moment to see if there's any public comment.
This is Crystal Duarte. I don't see anyone raising their hands for public comment. I did want to remind everyone that we can only use the chat for administrative purposes. So if you're having difficulty with Zoom or something like that, you can reach out. Everything in the chat is part of the public record. So we would ask that you not utilize chat, and also please refrain as members from texting and each other during the meeting.
And still no public comment?
I don't see anyone raising their hand or coming off of mute.
Okay, we'll go to the next agenda item, which is item number 3, to review and approve minutes from the April 19th, 2023 response subcommittee meeting.
And Chair Kearns, this is Crystal Duarte for the record. Gina is joining us now, our final member.
Oh, okay, great. So I'll open it up to the committee members if anyone has any comments or any thing they would like to submit for changes to the subcommittee meeting minutes from April 19th. Okay, hearing none, I would open it up for a motion to approve the minutes.
This is Shayla Holmes for the record. I'll make a motion to approve the April 19th, 2023 meeting minutes.
Christine Payson, I'll second.
Great, thank you, Shayla, for putting in the motion, and Christine for seconding that. All in favor of the meeting's minutes being approved, say aye.
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 Anyone opposed? And one abstaining?
I'm abstaining from the vote. Thank you.
Great. That was Dr. Woodard for the record. Okay, great. The committee meeting minutes are approved. We will move on to agenda item number 4, which is a presentation on opioid antagonist saturation plan. And I will hand it over to our presenter, Michelle Berry, who's the Senior Project Manager, and Morgan Green, the Project Coordinator for the Center for Application of Substance Abuse Technologies out of UNR.
Good morning, everyone. Thanks for inviting us. So I just wanted to give a quick update in regards to where we are with the current saturation plan. So as part of the State Opioid Response Grant third round, we were asked to put together a saturation plan specifically targeting opioid antagonists and ensuring that we were utilizing and distributing naloxone to our best ability in a way that was going to be beneficial. And so we really ensured that we tried to include many of our partners who really are part of this distribution component to make sure that we're hitting those locations that are really the highest risk. And so when we were looking at this based on SAMHSA guidance, we, as a state, settled on trying to get opiate antagonists at 8% of witnessed overdoses. Based on the numbers that we had in 2022 at that time, that came out to be 115,000 units distributed annually. For context, during that previous year, we had distributed just under 28,000 kits. So you can see that's a very large discrepancy between what would be identified as a saturation versus what we were capable of doing at that time. We found that we do not have the infrastructure at this point to distribute at that number. We just don't have the distributing partners. We don't have in place the ability to really get that amount out unless you need to rent a truck or a plane and just chuck it out the back of it. So in order to better kind of develop this over the next few years, we set much smaller goals, with year one being 40,000 units distributed and year two being 55,000 units distributed to help start growing that distribution. You can go to the next slide. So in order to do that and ensure that we were targeting those populations that are of highest risk, we wanted to start with improving relationships with industry. Nevada is really unique in the type of industry. We rely so heavily on tourism, and really our populations are pretty much around a lot of these industries, especially those that are really based around risky behaviors such as gambling, sporting events, cannabis dispensaries, bars and clubs, sex industry, all of those that really kind of invite more of an open kind of setting for individuals to engage in behaviors that they maybe generally wouldn't have done so before. And so trying to build those relationships and then expand jail-based distribution and relationships with criminal justice agencies. We know that some of the highest risk individuals are those that are coming out of incarceration. And then initiate emergency room distribution, working specifically with the Bridge as that is going into place, and Zero Suicide, who we're specifically working with hospital systems, because we know that oftentimes that is an easy point of contact for individuals. Increase availability of harm reduction vending machines, especially since they can be so easily utilized in more rural locations where we just don't have the resources to make sure that people are there all the time. And then work specifically with the Attorney General's office to reduce barriers through any sort of legislation. So really trying to ensure that we're available to help guide any of that as needed. Go to the next one. Thank you. So in order to target these underrepresented populations, we want to increase production distribution of culturally appropriate transit materials. We know that English is not the only language in Nevada, and because of that, we're missing a large population if we're only limiting that as our primary target. We also want to make sure that we're data driven, so really continue partnership with the OD2A to ensure that we are recognizing where those hotspots are and what those populations are that we need to best target. Expand partnerships with community organizations, especially those that are well connected with BIPOC communities, including human trafficking response programs, vaccination systems, crisis centers, and then recruit faith-based organizations to really kind of build out a lot of this response, and then engage with Minority Health Equity Coalition to ensure that we're going with the best guidance and we're using the right language as we go out to meet these populations. Okay, go to the next one. Thank you. So through this, we really wanted to kind of continue to build this infrastructure based around those previous pieces. And so you can see we've set several goals and activities over the next 2 years to help us move this piece forward. With each one of those X's saying, you know, we want to hit these points within each one of these quarters. You can go to the next one. So this is where, oh, it didn't pop up. I'm sorry, there should be check marks in this one. I don't know why they didn't show up. So there are check marks. We are the only thing that we're current on all of that, except with the labor association for Q3. We haven't quite found our labor association for this quarter, but we are up to date on all of those others. There should be check marks there. I apologize. So we are on good track in keeping up with our distribution and making sure that we are hitting our points. Go to the next one. And so you can kind of get an idea of exactly where we are. Here's our current distribution. So we look at our 6-month period. So between this last 6 months, we've distributed 17,305 units out into our communities for distribution. That's not including law enforcement, just as a record. That's a whole different ballgame. And so through that, we're also partnering with Southern Nevada Health District, who has also distributed through SOAR-funded 2,167 units. But Southern Nevada Health District also has some funding to help provide their own. So with those numbers, we should be over that 20,000 mark. We haven't received those yet, but we will for the annual. So we can see we're pretty on par with our goal for 40,000 this year. So fingers crossed. Go to the next one. And then you can see the distribution sites by county. So we still have several counties that we don't have established distribution sites within. We are working with coalitions, but coalitions oftentimes don't necessarily have an individual who is located in one of those counties at all times. So it's one of the reasons we don't count those as having a permanent distribution site where somebody can walk in at any point in time to obtain it. And so those are really areas that we still need to heavily target and find solid partners that people are willing to work with in those areas. Go to the next one. And just because I know that this is one of the things that we are all hearing about, is that the FDA has approved over-the-counter naloxone. So Narcan in itself will be moving to over-the-counter as production continues to develop. While it received approval at the end of March, it will not be available till later this year, from what we have been told, just due to the way that production has to occur. And because of that, they are still determining price setting. So we don't know what that price is, if it's going to drop from the traditional $72 per dose, or if they're going to have something that's lower. They're also attempting right now to negotiate with a lot of our insurance companies to see if they can maintain it as an insured benefit, but there is no promise to that either. So there is a lot of concern that this is going to really become a barrier for a lot of individuals if they do have to go to a pharmacy. If they do have to go to a store to purchase this, it's going to be out of the reach for a lot of our highest risk populations. So something to keep in mind, that we are still going to need to put funds aside to help support this. The second component is that there is a second opioid antagonist medication that is expecting to receive FDA approval imminently. So nalfenamine, the injection has already been approved. The nasal spray is pending. And so that is an alternative that is going to be coming on the market, so we can also use. The early research is showing that it does have a better potential for reversal of fentanyl-based overdoses. So that is something that we are hoping to continue to see grow and expand, to give us another option as our drug supply continues to change and keep us on our toes. You can go to the next one, please. So one of the big gaps that we are seeing is that right now the state opioid response grant is the primary funder for the purchase of opioid antagonist medication. And as our distribution numbers do continue to grow, that is becoming a strain on the grant, as we have multiple different demands on this funding source. So we really do need to expand exactly what can help fund the continued purchase of naloxone, or an antagonist in general, so that we don't continue to run into shortages. And I know AB 156 is currently going through legislation that is there to put together a fund from multiple different sources to help kind of support this ongoing. But it is something we do need to continue to talk about and keep in mind, because and we don't know how much these other antagonist medications are going to be. So it's really hard to predict what our budget's going to be moving forward until we get some of those numbers in place. Next, please. And then, of course, our contact information. I was told to keep it quick and short, so there we go.
Morgan, thank you for all of that. We appreciate all of the efforts of you and Michelle for this important program. I have some questions, I know, but I'll open it up to the committee members to see if anyone has questions they'd like to ask before I ask mine.
This is Shayla Holmes. I have a question. Thank you, Morgan. I appreciate you, and I appreciate all of the work that we've been able to do with you, at least out here in Lyon. When you showed the sites, I'm just curious if perhaps, as you also mentioned that your funding source is being tapped as you guys are trying to expand, and I can only speak from my firsthand knowledge of Lyon County, but I see 2 distribution sites. But I feel like, and I'm not sure if this is a universal issue throughout these counties, but I know I'm one site, so I'm perhaps counted as that in that 2, but I'm actually distributing throughout 4 sites that are open full-time, staffed full-time, because I'm Lyon County's, we've got this broad geographical range that we serve. So I'm not sure if
you're right. A lot of times we're counting these as organizations, not just necessarily sites. So a lot of these are the number of organizations that are doing it, because they don't always tell us the number of sites that they have. So
right.
so
Yeah, my guess is my other
that's a
site
really
is
good
RNC,
point.
which is probably 4 also. So I wonder, I mean, maybe that's just something we need to work with you to make sure that we get that updated, because I think
That'd be
that would
great.
show a bit, another reason why you might be spending so much money on 2 sites, right? Because it's really probably more like 8.
That would be wonderful, because we'd love to get as accurate as we can.
I see Christine Payson has her hand up. Christine?
Thank you. Could I just get the spelling on that new antagonist medicine that's about to come out? I didn't have my pen at the ready.
I was gonna say, I'm not even gonna try to spell it. I will let you look at it on the screen.
Thank you.
Christine, was that your only question, or did you have another one?
That was it. Thank you.
Okay. Any other questions from the committee?
This is Shayla. I have one more, if that's okay. You mentioned on one of your slides, perhaps some private partnerships for like the harm reduction vending machines. And I was just curious if you have had any success with any of those, as we struggle in a lot of our rural counties to get buy-in to some of those vending machines, and some of those places you had listed, such as bars, I think are fabulous ways to work around that. And I was just curious if anybody's actually bought into that yet.
Morgan, for the record, so we are working heavily with a lot of the bars, at least in Washoe County. It's really where our pilot's been on bar partnership. We haven't worked with them in the vending machine component, at least, but there is heavy distribution through anonymous boxes at a lot of our locations now. That seems to have been really effective. They've been amazing partners and are a lot more open to it than maybe some other community resources. And people don't seem to feel quite the shame or stigma in terms of reaching out for assistance at those locations. Rural communities have been a little bit more difficult in regards to kind of that buy-in, especially around the vending machines. We do try to keep there are some requirements in order to have a vending machine in terms of internet access, certain location protection from weather that needs to be in place, in those sorts of things. So that's kind of limiting for a lot of these locations, that they don't necessarily have, because I mean, bars don't necessarily need to have great internet access, because what are they doing? Like, that's not normally what people are there for. So that's kind of one of the big limitations. And we do try to place them in locations too that can provide kind of maybe some other assistants that have like peer recovery specialists that are close by that can answer questions or kind of help do that guidance so people are comfortable coming in for help at the same time. So there are some pieces that also go with that.
Thank you for that. I had a couple of questions. I'll kind of group them all together. I know for a while it was difficult to get naloxone. Are we getting it now within the state? And then the other question is, are you getting feedback on that naloxone that you're distributing? Is it getting used or is it expiring? And if it is getting used, are you getting feedback on how many doses per overdose on average?
So great questions. First, I mean, we do still have some delays in terms of getting the orders put into place. And I think a lot of that is due just specifically to really kind of strained resources at the state level in terms of personnel shortages. So there are some delays still occurring at that level. We do have naloxone now. We received another shipment last week, so at least we are good at the moment. As for those other questions, we do track naloxone. Usage is a self-report. So there's always going to be, we're always going to have fewer numbers reported back to us than are actually happening, to be honest. But when people do come in, we do ask that they fill out that quick questionnaire that does include, you know, is this a refill? Why is this a refill? Was it, you know, is there previous usage? In terms of the amount, most of that we're just getting from word of mouth from a lot of our community partners that are working with individuals in outreach components. And we really are, again, continuing to hear that it's taking 4 to 6 doses for reversal with the fentanyl at the moment. We're hoping that with this new opioid antagonist medication, we can decrease that a little bit, which might end up saving us some money. So
that's awesome. Thank you. I just wanted to highlight, I think most of you know, I'm physically located in Las Vegas. And this past weekend was EDC, and there was a news story about naloxone distribution that was done. So that's another area I think that we're hitting as some of our different festivals and those sorts of things. And then the only last question I have is, are you doing just nasal, or are you also distributing injectable?
great. Currently, we have purchased the nasal. With OD2A has been kind enough to help provide some extra funding for naloxone purchase. Through that, we are also purchasing some injectable, so that will also be available. We've been hearing on the street that some individuals actually prefer it because it seems to be a little bit easier on the fentanyl reversal, as well as a little bit less in terms of the withdrawal symptoms than the nasal spray has. So there is a demand that's coming out with it. So there is going to be some of that injectable available.
I see Dr. Woodard's hand went up. Please, Dr. Woodard, go ahead.
Thank you, Stephanie Woodard, for the record. Wondering if we're also collecting data from Medicaid to look at how many prescriptions they're also filling for the population, and seeing if we're also experiencing an increase in the number of naloxone prescriptions through the Medicaid system.
That's a great question. We have not requested that information recently. The last time we did, we saw that the people were not filling their prescriptions. So there's a big discrepancy between the number of physicians writing the prescription and the number of individuals who are actually filling that prescription. They're just not doing it for whatever reason. And so that hasn't been necessarily our most effective way of getting it out. And which makes me happy in the fact that it's not necessarily a physician educational issue. It's more of just getting the population to actually fill the prescription.
Chair, if I may.
Please go ahead, Dr.
Just for follow-up, Stephanie Woodard for the record. I'm wondering if then there isn't an opportunity for conversations with pharmacies, especially if individuals are going to those pharmacies to fill other prescriptions, and those pharmacies can see if an individual is being prescribed an opioid medication, to provide some of that counseling and support, and offering naloxone at point of distribution or dispensing. And then also possibly working with our state Medicaid agency to talk about maybe a technical bulletin or to providers around maybe some additional support and coaching around the importance of filling all of their prescriptions, including the naloxone prescription, if they're also simultaneously being prescribed pain medications.
I think those are all great suggestions that we should probably still pursue, because that was one of my thoughts too, especially in the counties you had listed that didn't have distribution sites. Is there any way, if there's a pharmacy, to work with those to get those pharmacies to distribute even the over the counter? So I think some work that we can look into.
Definitely.
Morgan, thank you so much for presenting. We really appreciate it.
Thank you.
At this point, we'll go on to the next agenda item, which is agenda item number 5, a presentation on community naloxone access. And we've invited Callie. I don't want to mess up your last name. I'll let you introduce yourself, but Callie is an emergency department nurse in Valley Hospital. So Callie, please go ahead.
Thank you. Can you hear me well?
Yes.
Okay, sweet. So yes, my name is Callie Getacho, and I'm a registered nurse here in Las Vegas in the emergency department. Primarily work at Valley Hospital Medical Center, but also at St. Rose now. And I'm just going to kind of give a quick overview on the impact that the opioid epidemic has on our community here, and how it's led me on a path to be here today. I'm going to start with the next slide, just some statistics.
Kelly, I just wanted to double check. This is Crystal Duarte for the record. I had some of your slides, I think, are incorporated into item number 6.
Okay.
Or did I miss something?
I'm not sure yet. Let's see the next slide, please. Let's see. One more. Yes, that's good. Yes, that's included. Awesome. So with the opioid, just some statistics here. Opioid-related overdose deaths has increased by 30% across the nation. And here in Nevada, I was in a 42% increase in opioid-related overdose deaths. And with fentanyl, there's a 227% increase, with a 23% increase in opioid-related emergency department encounters. And although I personally have noticed an increase in fentanyl overdoses working in the ER here in Las Vegas, I found the next slide is quite chilling. I was introduced to these slides as a heat map when I was taking an Narcan class with the Southern Nevada Health District with Jessica. And so these are fentanyl-related deaths by resident zip code in 2016. The red indicates that there's been at least 4 deaths related to fentanyl overdoses. And if we move past the COVID pandemic into 2022, this is what we're dealing with. And as an ER nurse, I've noticed that there's been an increase with fentanyl in our community. And it's not just with the patients that are using fentanyl as a drug of choice with their substance use disorder, but there's also a lot of patients that I've seen who unknowingly or unintentionally overdose on fentanyl, thinking that they were using a different substance. And one of the main reasons, if not the reason to why I'm here today, is after seeing and caring for and discharging many patients with Narcan prescriptions that were brought into the ER, our ER, for fentanyl overdoses, time and time again, I noticed, and I battle with discharging the patients with Narcan prescriptions, mostly papered prescriptions, and then they never fill it. I can't say for everyone, but the majority of our patients are from undeserved and low income, thank you, communities. And one patient in particular that I had overdosed over 3 times in a week, seen at different hospitals. And I bluntly asked him if he think he was going to fill his prescription, and he told me that he honestly couldn't afford it. He tried it in the past and it cost too much. And that kind of led me to meet a lot of great people who's trying to make changes and who are making changes in the community, and particularly with Narcan OD kits. And Yes, I'm going to hand it over to Sarah and Josh, who have found a way to provide Narcan and OD kits free of charge to people in California next door. So I'm going to have them take over with the California Bridge program in the next slide.
I'll just go ahead and introduce our work. I'm Sarah Wendells. I'm the National Program Director. You might have heard of our work through the name of ED Bridge or CA Bridge. And I'll just mention that, in fact, what we've been doing is working nationally for over 3 years, really trying to bring some of these results that you're seeing on the screen, some of the training and technical assistance, all the tools, the knowledge that we have in working directly with patients in the emergency department to everybody across the country. And so we have a very highly mission-driven team that is very clinically focused, really trying to modify every detail of our work on a daily basis to make sure that you all across the country have all of this information to be able to make effective decisions for your entire state. And so here on the screen, you'll see I'm the National Program Director, but Josh Leftig, I'm going to go ahead and pass it off to him as well. If you could go to the next slide, I just want to make sure that you are aware of the funding for this work. As I said, we're mission driven, but we are funded through grants at this moment to be able to be here today through the Foundation for Opioid Response Efforts. And then specifically, we have done a bit of work with a few of your leaders in Nevada through the Opioid Response Network, specifically working to really elevate and empower some of the local clinical champions in the state to be able to take some of these tools and really run with it. We really want to support you all as you're trying to really address these huge gaps in treatment access, huge gaps in naloxone access. So with that, I'll pass it off to Josh.
Great. Thank you all for having me. I'm Josh Leftig. I'm one of the founding members of Bridge and California Bridge. And I've had the privilege of being the Director of Harm Reduction and initiating ED-based naloxone distribution at one hospital. And now we've spread to 165 hospitals in California and have set up low barrier. So I have the scars to prove I've been down this journey of really, establishing low barrier distribution and out of the ED and kind of navigating all the policy issues that surround that. And so in these next set of slides, I'm going to go through what is the California Bridge model, which talks about access to treatment in general. And then specifically, we'll dive into the naloxone piece. So we're going to thank you, Callie, for giving us the context, and also thank you for reaching out to me and us for assistance, technical assistance on how to cut through and kind of get to the end result that can be hopefully satisfactory for Nevada. Next slide, please. So the Bridge impact to date, this is just sort of the scope of where we've been. We started with 4 hospitals in 2017, and now we're at over 250. We're actually at 278 hospitals. They're in California, and what they're doing is using the ED as a portal for connecting people to treatment. So actually engaging people, having navigators, peer navigators embedded in the ED, and they're engaged patients. They've had over 200,000 that have been seen for substance use disorder. Over 176 have identified with substance use disorder. So a lot of the problem is people are not actually even, they're coming in for abscesses or other complaints or abdominal pain or chest pain and whatever, but actually no one's actually getting to the underlying use disorder that's driving all these visits. So that's a key metric. And then MAT, medication for addiction treatment, which is in the ED setting, is buprenorphine. So actually initiating addiction treatment right in the ED, over 70,000 prescriptions or just actually administrations of buprenorphine right in the ED. And then relevant to what we're talking about here is naloxone toolkits of over 150,000 toolkits that have been set up in the EDs for free distribution. Next slide, please. Of course, this is no surprise to anyone. I think this is just the spike in overdose deaths across the country, over 100,000 last year. And I think the relevant thing is that, everything building up till this fentanyl spike, everything we were doing back in that era has to be changed. Like all the systems we had in place were designed to handle a low level of overdose fatalities. Now that we're having this incredible spike, we need to reconsider everything and set up new systems of care. Next slide, please. This is a double slide double graph that shows on the bottom, we've done work with opioid stewardship, and law enforcement has done work with dealing with the supply, cutting off the supply of opioids to the community. The next step in the work that needs to be done is, see, despite all that, we've had this climbing overdose death rate, which is said on the top. So in spite of managing, doing efforts to curb the supply of opioids in our community, we're not doing a great job of addressing the use disorders and providing access to treatment. So that's the other piece that goes along with supply, is access to treatment, because that same population, just because you turn off the supply, someone doesn't suddenly magically not have a substance use disorder. They will just go to the cartels that are supplying plenty of fentanyl to our communities. Next slide. These are some of the abbreviations that we're going to be using. MOUD, medication for opioid use disorder, and MAT, medication for addiction treatment or medication assisted treatment. Next slide. Sorry, I'm going to go. I realize we're limited on time, so I'm going to be skipping through quickly. Buprenorphine, this is the first line evidence for ED-based treatment of opioid use disorder. It stabilizes patients with opioid use disorder, and it comes in many formulations. It can come sublingually or injectable, but this is what we're using in the ED, and is any licensed prescriber can use this medication. Next slide, please. Naloxone, this is what we were talking about earlier. The naloxone nasal spray is incredibly safe. In fact, so safe that for decades its community distribution has been normalized across the country, so that you can, for instance, putting as Morgan Green is putting it in vending machines and drop boxes. If you think about it, there's not a lot of medications that are allowed to be just passed out this way. So that's thanks to its incredible safety profile. And it is a reversal agent that reverses an overdose. Next slide. This is the mechanism that it does. It basically displaces the opioid on the mu receptor in the brain, and reverses the respiratory depression that leads to apnea and death by occupying that receptor for 30 to 90 minutes. Next slide. As you alluded to in the prior presentation, so prescribing naloxone, the problem with prescribing that we've found is that only 11% of patients, this is in the ED setting, only 11% that should be getting a naloxone prescription because they do have a risk of overdose, or if they're being co-prescribed opioids, or they have a use disorder, are actually receiving a prescription. And then more alarmingly, only 1.6% are actually filling that prescription. So the fill rate is incredibly low. So this strategy of prescribing, there's definitely room to improve there. And I think there is, as was mentioned earlier, there is room to do some education around that. But this is not a, this is why most places that are engaged in this topic are moving to take home in-hand naloxone as the gold standard, so that you're not relying on a patient to leave a clinical setting, go to a pharmacy, fill a prescription, and have that on hand, that you're actually giving it in hand. Next slide. Well, I start from the emergency department. Next slide, please. Emergency departments are the ultimate safety net. They're visible, they're easily accessible, and they're often near public transportation. There's a whole infrastructure that usually centers around emergency departments. They offer all hours access. So 24/7, 365, your emergency department will be open and available. They can provide acute psychiatric stabilization. Many of our highest risk patients have co-occurring psychiatric disorders that need stabilization as well. They have same-day treatment, and they can navigate to ongoing care. A lot of what's done in the ED is acute stabilization and then connecting to follow-up care. They provide a clinical link to shelters and community treatment programs. Next slide. Also, EDs are well distributed geographically. So, there's Southern Nevada has a concentration around the Las Vegas area, but additionally, you have lots of ED safety nets that serve over 250,000 in rural Nevada. And this is just a map that shows some of that rural safety net. Next slide. The other thing is treatment when it matters most. Fatalities spike in the first 2 days after an ED treatment for a non-fatal overdose. So where are you going to end up? You're going to end up in the ED. Typically, if you survived your overdose, you're often going to end up in the emergency department. And within that first, the data reveals that there's this 48-hour window of time where you have an increased mortality after that non-fatal overdose. So we've done a reversal and we send people out figuring that our work is done. And really those patients need to be engaged, started on buprenorphine, given take-home naloxone right there. Like this is a moment that is a key moment to intervene, much like after you've had a heart attack or a stroke. There's this acute stabilization period. Most of those, if you had a heart attack or stroke, you're being hospitalized. We're not saying that you should be hospitalized, but we're saying that there needs to be a care package, and that the risk associated with that moment in time, that 48-hour period, needs to be given attention to. And there's really no one else can intervene. You can't say, okay, well, we're going to have you follow up in this clinic within this 48 hours. Often these are happening on weekend nights, in the evenings, odd hours. So the ED really has to have the capacity to engage right in that moment and provide a care package. Next slide. The bridge model sort of has three elements. One is low barrier treatment. So having the staff, the clinical staff, know about buprenorphine, be able to administer and prescribe buprenorphine right there immediately. So those patients who are coming to the ED, who are out of care, typically, the high-risk population that's in the ED can actually be initially started on treatment. So you go from being unstable, often chaotic substance use, to being in treatment in one step right in the ED. No going and finding some appointment that's going to be may or may not accept your insurance, et cetera. Secondly is connection to care and community. So we advocate for having peer navigators right in the ED. So they're engaging patients, they're modeling language and behavior, and they're making sure that there's a follow-up plan and an appointment for that patient to be started in treatment, in outpatient treatment. And a culture of harm reduction. So that involves distributing naloxone, and also modeling language and behavior that's appropriate for the clinical setting. Patients with substance use disorder, not referring to people as junkies or addicts, or using language that is highly stigmatizing and leads to poorer patient outcomes. Next slide. The bridge model. So yeah, when you start buprenorphine in the ED, you can more than double retention and treatment at 30 days, which is the typical numbers are usually 1 in 10. Most patients are not accessing treatment. So these are major interventions. Additionally, having navigators more than doubles patient retention and treatment in 30 days. So these, and if you look through the references, there's great articles that'll go into deeper dive into those numbers and the effectiveness. And naloxone distribution from the ED, an estimated 16% of recipients of ED distributed naloxone go on to reverse an overdose. So that gives you a number needed to treat of 6.2, which is incredibly low for much of what we do. Giving aspirin for an MI is like a number needed to treat of like 30. So this is a high impact intervention. Next slide. Meeting patients where they're at. So we have high-risk populations that are being seen in the ED. EDs are natural magnets. Like the more you're struggling with substance use disorder, the more likely you are to be in the emergency department as your life is falling apart, as your social support is falling apart. So it naturally concentrates people that are really high risk, and an estimated 50% of ED visits have some connection to substance use disorder. And EDs have a legal obligation to treat patients regardless of insurance or ability to pay. So we're legally mandated to provide care on demand 24/7. And the bridge model also decreases length of stay, readmission rates, readmission to ICU rates, and expenses up to $18,000 per encounter, because you're actually delivering standard of care and not having these long drawn out unnecessary workups. You're actually treating the underlying disorder. So you decrease the recidivism of patients who are just going through a revolving door and continuing to visit the ED and not getting the care they need. Next slide. So yeah, instead of a revolving door of frequent flyers with little or no intervention, each encounter becomes an opportunity to re-engage and immediately restart addiction treatment. Next slide. I'm going to focus on naloxone distribution. So right now in Nevada, just like in California, Nevada's distribution is permitted via standing order. And I cited the statutory code. And there is a mechanism for EDs to apply to naloxone, thanks to Morgan Green and her colleagues at CASAT. So they can apply. However, there's low barrier distribution is not occurring, and Callie can attest to that. She told me this, that about her patient that was trying to get naloxone, and she struggled. It was really frustrating. She felt like this patient was going to die if she couldn't get him naloxone, and there was really no way to get it out of the ED setting, which is really tragic. So why is that happening? So one, there is a complex regulatory involvement that has a chilling effect on EDs and hospital participations. It's much easier to provide it in a library or a school, a place that doesn't have all these rules around handling medications. So hospitals are so rule bound that they can't, low barrier distribution is very challenging. Without guidance and regulation exemption, EDs are forced to follow complicated protocols with minimal impact. Next slide. So what's working well? So in California, we face this exact same problem. Our statutes are very similar, and our ability to distribute rings via standing order is also the same. So we asked our Board of Pharmacy, Health and Human Services, and Department of Public Health to exempt EDs from the regulations, provided that we store public distribution naloxone separately from our hospital formulary medications, and that we also followed specific policies in the form of standard operation protocols, or SOPs, that we would be permitted to do this distribution. And then we additionally provided these SOPs to hospitals so that they would have a playbook where they would be able to implement. Next slide. So let's talk about some of the impact. So we had, before setting up the system, we were doing about 7 in-hand, this is our pilot site, we had 7 in-hand kits per month. That went up 65x. So we were going up to around 500 kits. So it was day and night. Like, it was an incredibly impactful intervention. Next slide. And then statewide, there were no hospitals that were able to do this, much like Nevada. That's where we started out in 2018. And then now we're up to 165 EDs that are distributing naloxone. Like I said, over 155 kits are available for free distribution. There's I think there was a slide that maybe we had on was the skip slide, but there's one, another effect was the catalyst effect, where there was 11 community organizations. Oh, there we go. Local community programs began naloxone distribution as a direct result of the pilot site program. So once the ED engages, they normalize naloxone distribution and harm reduction in this manner. And so all these really important organizations that were engaging people with high risk felt that they could also join in. And we actually directly provided from the emergency department to these nonprofits to get them started. And then we directed them on how to apply for their own supply and really set up their own program. Next slide. This is the structure, as I understand it, for Nevada, which is a mirror to our program in California. You have a set of funding sources that come in, and CASAT is able to receive these applications from these qualified entities, which are down at the bottom, including emergency departments, and then they approve the orders, and the naloxone manufacturer sends them out to the ED. So basically, the state is just responsible for running this program, which actually is pretty light touch in terms of how many people are involved in it. Sort of the administrative overhead is on the top part that the state is responsible for. Is very light. And then you use existing infrastructure on the bottom, like all these agencies that are engaging folks that are high risk, and you use that existing staffing and capacity to engage in distribution. Next slide. Which regulations require exemption? So the regulatory domains include medication dispensing, labeling, maintenance, storage, packaging, and security. That's sort of the family of legislative domains that govern medications in the hospital and acute care setting. And the regulations that were exempted in California. So basically, I took the exemptions that we needed to get exempted from in California and found the corresponding regulations in Nevada. And I've included that as an addendum. So the entire list of regulations, both in California and Nevada, that are similar are listed in an addendum that will be shared with everyone publicly. Next slide. Recommendation. So the recommendation is that there's a request sent to the state regulatory bodies, which in this case would be the Nevada Board of Pharmacy, the Nevada Department of Health and Human Services, or DHHS, and the Nevada Division of Public Health and Behavioral Health, DPBH, that they request low barrier distribution from emergency departments. I mean, they permit low barrier distribution from emergency departments, and they permit EDs to adopt a naloxone specific standard operating protocol, or SOP, for public naloxone distribution via standing order. Next slide, please. Oh, and I provided, there's draft language is provided for that, that how the request is. So basically how we've posted, can you go back one slide? Sorry. So draft language of the way the exemption, the permissions and the exemption that we found have worked well in California has been modified, and a copy of that draft language is provided for a Nevada specific version of that statement from those regulatory bodies. Next slide. And then additionally, a template documents be made available in healthcare systems. So hospitals really need a playbook for this. It's not, they're not really equipped to do community distribution just without, like, if you ask a hospital, okay, start doing community distribution, they will immediately put the medications in their pharmacy and start to use their pharmacy protocols in absence of having some other set of guidelines. So what we recommend is that template documents be made available to healthcare systems, and those include a standard operating protocol, a standing order, template standing orders, template log sheets, program description, all that. And that's what we've been using, that we found that's been very effective. So they can literally just take 10 minutes, write in their hospital name in all these documents, and then they have an entire package, a program that they can start to utilize immediately. And I've provided draft template documentations in the addendum. And then finally, just consider opioid settlement funds and other funding opportunities for naloxone. There are opportunities to get discounts on naloxone from manufacturers in the form of public interest pricing, which should be explored if it hasn't already been, which I imagine it already has been. Fentanyl test strips are a great intervention. These are very inexpensive. That's usually $1 to $2. And these can prevent an overdose. ED-based peer support navigators are fantastic. You can also partner with community. Some of these navigators are working in the treatment programs, and they will also cross over and work in the ED. But having someone in the ED to engage this really high risk population that's going into the EDs every day and connect them to care is fantastic. And training for healthcare providers in ED-based initiation of medication for opioid use disorder. So most people who are practicing emergency medicine today did not have addiction treatment in their or training in addiction and buprenorphine. And so we've at California Bridge, we have provide technical assistance, or now that we're Bridge, because we're leaving California, moving on. We have provide technical assistance, and we also have a toolkit that's publicly available for prescribers to learn how to initiate treatment with buprenorphine. And that's what I have. I would love to hear any questions.
First of all, Callie, Sarah, and Josh, thank you so much for this presentation and for the work that you're undertaking and saving the lives of many citizens. So I know I have again a couple of questions, but I'll open it up to our committee members first. Any questions from the committee members? Hearing none, I'll go ahead and ask mine. I know you laid out a lot of great work that's been done that can be adopted here within our state. But one of the questions, and I'll direct this to whomever wants to answer, but also Callie, for you, being that you're active in our ER here in the state. Is it a case of the peer navigators would be the ones that would be providing the naloxone, as well as, offering other types of services as well? And does that help to alleviate the issues with hospital personnel providing, even though it's over-the-counter medication, to people that you're seeing in your emergency departments? That's my first question.
If we could get what California Bridge has going on, it would essentially be me, just like I'm giving them prescription paper at this time. I will be able to give that patient a Narcan OTK right there and there. So, and then for people who just want to walk in, grab it, not being checked in for other reasons, it could be family members, friends of people who are dealing with substance use, opiate-related substance use. It would just be readily available rather than giving them a prescription paper that they're most likely not going to fill due to various reasons, stigma, income, not being able to afford it.
Yeah, if I can add into, that's absolutely right. And the part of the way, previous models required the pharmacist be involved, which became a bottleneck. So this allows any staff member, whether it's a clinician, whether it's a nurse, whether it's a peer navigator, they can all train in and become engaged in the program and distribute naloxone. So it's like it's an army of many. It's like the entire healthcare team can be a part of the program.
Great, thank you for clearing that up for me. And then my other question is, I know that there are some states, so you talked about the initiation of buprenorphine within the emergency department. Is there any component for follow-up afterwards? And one state I know, I can't remember, it's up in the Northeast, is starting to use community paramedicine, trying to get them to be able to distribute like a 3-day supply until someone can get in, because sometimes the waiting list to get in for treatment is really long. So can you speak to that?
Yeah, so exactly. So one, we encourage, this is again like normalization of treatment. So once the ED sort of steps in and starts doing this, it usually primes the rest of, and they're finding their follow-up clinic and finding their partners in their community, and it usually encourages your follow-up clinics to start to have drop-in appointments available or increase their availability and their access to treatment as the ED initiates it. So we found that's been really beneficial for communities. Again, just like naloxone, it becomes a catalyst for the community. Once the ED starts, then the rest of the community kind of comes along. And there's also, as you mentioned, the paramedicine and the mobile integrated health partners, especially. I've seen a lot of that in Southern Nevada. They have an amazing program through Las Vegas Fire and Rescue is doing some great stuff. And I'm sure it's happening in other places in the state. So and they're starting with buprenorphine treatment initiations in the field as well, and helping exactly what you're saying, kind of connecting this network of care so people aren't falling through the cracks from the ED to their follow-up. We also encourage people to do prescriptions from the ED that will give them plenty of time to stay in care until they get that appointment, even if it's giving a month supply in, say, a rural area where it's hard to get access.
I see that Dr. Morgan has raised her hand. So Dr. Morgan is the medical director. So if you would please, Dr. Morgan.
Sure, absolutely. Sorry, I had to jump on a couple minutes late. So Kelly Morgan, for the record. Yes, there are efforts underway to initiate community paramedics to be used kind of as the initial bridge while we are getting MAT and buprenorphine normalized basically in the emergency departments. There are peer navigators who are on their way, and there are efforts being made, at least in Southern Nevada, to start really trying to put the pieces together, not only within the Valley Health System, but within all of the hospital systems, and really kind of forming a solid coalition to provide these services and education to everybody, and then use community paramedics is the next step to bridge them into getting them into our community partners and making sure that there's much better communication between the emergency departments and our community partners to figure out where do these patients go from the ERs, so that we don't just have to use a very limited resource in our community paramedics to do this program. But right now they are the kind of that stopgap before we also then roll out buprenorphine in the field with all 911 ALS level providers. So there are massive efforts underway and some furious grant writing going on right now, by myself included, trying to get these pieces together, but it's coming pretty quickly. So just wanted to update the group on that.
Thank you for that. I appreciate it. Again, I open it up to any of the committee members if you have any other questions that may have come up. Hearing or seeing none, I want to again thank you guys for the outstanding work you're doing, and want to continue to support this as we can through this committee.
Thank you so much.
Thank you.
Okay, at this point, we'll move on to our next agenda item, which is agenda item number 7. You guys are welcome to stay, or if you need to jump off, whatever works for you all. We'll go to item 7 is the 2023 legislative session update, and I will pass it off to Vice Chair Holmes.
We will keep this brief. So there was the list that was sent out by Crystal with all of our agenda packets for the full list that SEI has put together with all of the updates on legislation. We will look at the ones that are more related to our response subcommittee. SB 4 has actually gotten a due pass out of its assembly workshop on 5/17, so it's moving right along. We've only got 2 weeks left in this session, so things are coming to a close here pretty quickly. With some of the stuff we heard today, I think SB 4 would be perhaps a really good piece of legislation to go check out, as it could perhaps support some of these prescriptions through that we've talked about through Fund Healthy for Nevada, or Fund for a Healthy Nevada. SB 35, we've talked about this in our last year's set of recommendations, so it's awesome to see some stuff moving forward that we've talked about in regards to changing the trafficking levels of fentanyl, and it's got a 5/19 assembly workshop. It was due pass as amend. Interesting, I'm not sure if it's on here or not, maybe it is. SB 412, was it SB 412? I don't think it was. One of them was working to, yeah, it was SB 412 maybe. Working to include Matt in regards to our jails and our incarceration facilities. And that seems to have snuck into this amendment on SB 35. So while SB 412 is not moving much right now, it seems that that might be making some traction in SB 35, where it was originally focusing on the trafficking levels. It's now added in that last amendment to encourage, if money allows, Matt within the jail system. So I think that that is still alive and well, just in a different bill. SB 197 has died, and SB 412, I think, is one that's sitting there with a waiver that hasn't had much going on. Next slide. On AB 132, this one for some reason I didn't look at, but that's okay. Overdose fatalities. So that one is moving right along, although it may have had something happen since 425. And then AB 156. This is the one, I'm sorry, that's made it to where Matt would be in our jails, but perhaps actually happening through SB 35. And this one it's got a waiver, but it hasn't been heard in the Senate at all. Its last status was on 421, but it's still in the Assembly, so it hasn't even been read in the Senate. Is there anything else? Next slide. Yeah, I think that's it. So does anybody have any other legislation that they would like to discuss or add to this list, or anything at all in regards to the conversation on our current legislation? I'm not seeing any hands. I don't see anybody jump in. Okay, I think we're able to move on to item number 8. Dr. Kearns, it's got my name on it, but it's got your name on the agenda, so I don't know which way we want to go.
It's fine. I can take it. I just wanted to add to what Vice Chair Holmes said, is that, as you noted, the updates are from the end of May. The end of April, so they're not current. I always invite everyone to go on our legislative website to see if you want to get any updates on those, any of those bills as they currently stand. So we'll move on to item number 8, the overview of recommendations received and next steps. Next slide, please. We basically had 4 recommendations from our response subcommittee. The first one is one that was a recommendation from last year, and that's to resolve the conflict between the Good Samaritan law and the drug-induced homicide law. I submitted this one because, you know, I keep hearing from the harm reduction community and those who work in our communities with people who use substances that they're not necessarily always calling when they witness someone overdose for fear of being arrested. And of course, our law enforcement it is, and that's part of why we had SB 35, needs something that they can use trying to reduce the supply of drugs that are in our community. But it seems to be a conflict. And I will say, in listening to the hearings on SB 35, the Good Sam law has come up in those hearings. And again, that impediment of people not wanting to call. And I heard some witness testimony where people said, you know, they were there and someone wouldn't call, so they had to call, or they administered naloxone. So I think we still need to do some more research on this to see if there's anything else that we can add or come to resolution. And maybe we will get some resolution on this through SB 35 as well, because like I said, there was a lot of talk about the Good Sam law. Possible presenters, you can see we provided links from previous presentations, and then possible future presentations are from Christine Pesa and Lisa Lee and Dr. Wagner. So I think we've got some more work to do on this, obviously. Moving on to the next, you can see, I'm not going to read all this to you, but it goes through what we had tried to do as part of our recommendation. And it does lay out some similar legislation that's been done in the state of Delaware and also in Rhode Island. So, and then there's research links that I welcome you all to go to look at those. The next slide. Okay, I'm sorry, go back to the previous slide. I missed that. This is recommendation number 2. I believe this is this is Shayla's recommendation. So Shayla, if you would like to add and speak to this.
You actually, I mean, I think you recapped it pretty well. It's in addition or perhaps complementary to your recommendation, although submitted separately around the same time, just proposing some legislative language from 2 different states that seem to have some success with aligning the Good Samaritan law with drug-induced homicide. And there is the link there where you can see all of the different states that have these codes, you know, within their revised statutes that we could potentially look at to encourage here.
Thank you. And I would add, I know Colorado recently passed an omnibus bill that was pretty comprehensive, that did have some penalties for weights on fentanyls and some other drugs, carfentanil and some others. But they also had a large complement of harm reduction and Good Sam law within that. I know also that our state is a qualitative state in terms of, from the forensic side, we do not quantitate the amount of drugs. So if, you know, we heard from the presentations that if someone came in and thought they had bought an oxy pill, but it was really a fake pressed pill that contained fentanyl, currently within our state, we can't tell you how much of that may have been Tylenol and how much of it was fentanyl. We just know that fentanyl is present. So there's a lot of conversation as well surrounding that. So I think, again, some of what's going to come out of that SB 35 will give us some good direction too on these 2 recommendations. We'll move on now to the 3rd recommendation. And I believe this was submitted by Dr. Woodard. The recommendation is for substance use disorder, mental health, and medication for opioid use disorder, assessment, treatment, recovery, support, pre-release case management availability in our incarcerated settings, and implementation challenges and opportunities, and a waiver for Medicaid coverage 90 days pre-release. For those of you that don't know, when someone is incarcerated, they lose their coverage for Medicaid because they are getting their medications through our jails and prisons. And that becomes a real impediment for people being able to then get their medications. And I'm not just talking about for substance use, I'm talking about all medications. So Dr. Woodard, if you want to add anything on this recommendation.
I don't have anything to add at this time. California was actually very successful in passing the first waiver of this kind, and we're seeing CMS really come alongside states to help them understand how they can use the 1115 waivers to really help to do in-reach and that necessary connectivity to care following release into the communities for continuity. And lots of great research as well as policy guidance to help us understand why it is so important for us to make sure that we've got that continuity into the community for release. So I included several of the links here as well.
Thank you. And the only other thing that I would add, I know in hearing some of the discussion and talking to people on SB 35 when MAT in our prisons and jails was discussed, it wasn't necessarily always a limitation in funding. Funding is a big piece of it. But as many of you are aware, in some of our frontier communities, it's a lack of providers being able to actually have and prescribe the medication assisted treatment. So that's something that's being looked at. And I know that out of the sheriffs and chiefs, they were looking for some amended language on that as well, to ensure, because as with people who are discharged from emergency departments, people who get out of our prisons and jails are at higher risk of overdose as well. So I think all important things to look at. Dr. Woodard, I know that you have Bill Teal doing that study. Do you want to just talk about that real briefly?
Sure. So through the Fund for Resilient Nevada, Bill Teal, who was overseeing Clark County Detention Center, has since retired from Las Vegas Metro and is now working on contract with us to explore the readiness of our community jails in being able to implement MAT or MOUD programs. I do think that it's important for us to really understand all of the obstacles, challenge, barriers, as well as opportunities to expand care in our incarcerated settings. And so he is working closely with the department to evaluate where all of the county-based jails are related to implementation. So he's doing that evaluation, and then we'll be working with us to provide a summary report so that we have a pretty global snapshot of where each of the jails are related to readiness.
Do you have any time frame on when he may be completing that at this point?
I don't off the top of my head. I'd need to check with Dawn.
Okay, thank you. And as noted here, that would be a great presentation once he does complete that work, I think, for our committee. I would open it up if any of our committee members have any questions at this point on these recommendations, or if any of the committee members have additional recommendations.
Chair Kearns, this is Crystal for the record. I do have the fourth recommendation on the slide now too.
Okay, I'm sorry. Go ahead to the next slide. I think this was your recommendation, Vice Chair Holmes. It's a recommendation for the wastewater-based epidemiology as a monitoring tool for public health, and looking at those analysis of biomarkers, which look at drugs, chemicals, and pathogens. If you would like to add any more depth, Vice Chair Holmes.
The only thing I want to add, so University of Nevada, Reno was working on wastewater-based epidemiology in response to COVID-19. So I know that they have started this work and have several localities participating, although it's not statewide. And there's lots of research to support that this type of technology could be utilized in response to not just opioids, but several illicit drugs as a whole, to be able to allow for a more targeted community response and provide some data and information that might not be currently available at that localized level, and could perhaps really trigger some innovation in regards to how we can respond to spikes and things of that nature.
I would add to that, I believe that UNLV was also doing some work with the wastewater-based epidemiology as well. So I think we do have some basis for this throughout the state already. So again, I'll open it up if there's any questions or any additional comments or recommendations. If I hear, and I don't think I hear any from any of the committee members, I would add that one of the other things that we're looking at, I don't know if it'll necessarily need to be a recommendation for this committee or maybe for that joint task force, but in working with Morgan Green out of Casat and Southern Nevada Health District, trying to do some targeted fentanyl awareness education throughout our state for our first responders. As many of you know, in Douglas County, months ago, some of the deputies were exposed to fentanyl when they were doing a law enforcement action and were treated and taken to the emergency department. And I have heard anecdotally that there are some places law enforcement wise that are pre-dosing themselves with naloxone before they go into to do actions. So we were trying to work to get some fentanyl awareness types of training throughout the state for our first responders. So again, I don't know if that's necessarily for this or for our joint task force. And that's the Advisory Committee for Resilient Nevada and the SURG committee members. So any thoughts or comments on that from our committee members? Dr. Woodard, please go ahead.
Thank you, Chair Kern, Stephanie Woodard for the record. I do think that it fits with some of the priorities that had been identified specifically for the joint task force. So at the very least, I would suggest making sure that it is heard and contemplated before that body as well.
Yeah, I think that's something I know out of our harm reduction meeting that we had, there were a couple of recommendations out of that were suggested to go to the joint task force. So that might be one we want to add. Are there any other recommendations or presenter suggestions from any of the committee members? I think we're going to have to work our suggestions a little more. So Crystal, have you gotten anything else? Do you want to push these back out to the committee members to see if there's any wordsmithing? I think that Shayla's recommendation number 2 and my recommendation are very similar. I feel like we need to follow some of the legislation that's currently going on to get updates, which hopefully we'll get updated on that have coming out of specifically, I know SB 35, but also others.
Crystal Duarte, for the record, we will have an update of the legislative session, I believe, at the July larger SURG meeting. And our meeting is really close to that as well. So I think that the survey for submitting recommendations remains open all the time. After July, we will need to start combining and taking what we learned from the session to try to formulate new recommendations. So I think, Chair Kearns, it would be great if in the meantime, if there are similar recommendations, if people can get together to refine those, that would be helpful. But I do understand that legislative session is kind of key to figuring out what we do next, and would just say in the meantime, please submit any recommendations that come up, any that you heard today. We aren't automatically putting our speakers' recommendations into the slate for the committee to review. So if you heard something today from a speaker that you want to elevate, please go back to their slides, which are posted. And I will post those addendum that Josh was mentioning. And please submit those recommendations.
Thank you for that. We'll move on to the next agenda item, which is item number 9, discussion of report out for July SURG meeting. Vice Chair Holmes, if you want to address this.
Thank you, Chair Kearns. I think you primed us well for this conversation as we need to report out in July on the work that our subcommittee has done. We've had 2 meetings, I believe the one in April and the one that we're having today. And then the one in July is right around that. I think it's right before. So thus far, we've got the 4 recommendations, 2 of which will most likely be merged together in some capacity. There may, and then the recommendations we heard today from our presenters, and we've had the presenters from today, as we didn't have any presentations from last meeting. So at this point in time, that is the wrap up, or the easy button as far as what our report out is to July. Is there any discussion regarding what the subcommittee would like to have included in that report out, or anything specific that they would like to note in regards to the 4 recommendations we have now, plus the 2 presentations we had today?
This is Terry Kearns for the record. Crystal, does our meeting happen before, our subcommittee meeting happen before or after the July SURG meeting? Do you know off the top of your head?
I was just looking, it happens after the July meeting. So July 12th at 2 p.m. is the larger SURG meeting. And July 17th at 9 a.m. is when we're scheduled to have our next response subcommittee meeting. That is one of the meetings we put on the calendar last year. And as the committee has experienced, if we don't feel like we're going to get a quorum, we have been moving those. So then the 17th is when we're currently scheduled to meet again. And if we need to move that, we will. But I think so far, we don't have anyone from our committee declining it. So I believe that's a good date.
Okay. What I would just say is, I think for that recommendation 1 and 2, we're really going to need to find out what is happening with the current legislation before we can really come to consensus or conclusion on what we're going to do with that recommendation. So we may want to add that in our report out to the SURG committee. Any other comments from the committee members? Okay, hearing none, I think we're ready to go on to the next agenda item, which is agenda item number 10. And it's for public comment. And again, we're open to public comment. Public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. And this is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. Is there any public comment?
I don't see any hands raised. Oh, I see a hand raised now.
Please, Dr. Morgan, go ahead.
Sure. So this is Dr. Kelly Morgan for the record. I just wanted to go ahead and back up the presentations that were done earlier today. I think one of the most important recommendations that can be made are to relook at the regulations from the Board of Pharmacy to help better enable naloxone and OD kit distribution within the hospital settings as a means of community harm risk reduction. I've come into contact with this twice, even in the last weekend, regarding patients, and it's been a real barrier. And I hope that the people that I saw actually were okay. I had to kind of makeshift some things to help ensure that hopefully they had access to Narcan because they weren't ready for treatment yet. So I just wanted to go ahead and stress that recommendation, I guess, to the committees that are hearing this, that efforts would, from a medical standpoint, efforts to allow for easy naloxone distribution within hospitals is of utmost importance, and really should be a top priority going forward. That's it.
Thank you for that. I don't think that we had that included as a recommendation, but that may be something that we want to put as a recommendation. And Crystal, I can work with you on some language for the committee, which we can look at is basically the bridge program and our next steps to try to get this implemented within our state. I think we're lucky to have many of our presenters and Dr. Morgan who are being leaders in this area currently, so that we can help them to get this not in their only in their hospitals, but trying to get it statewide. Any other public comment? Hearing none or seeing no hands raised, we'll move on to the next agenda item, which is agenda item number 11, which is our adjournment. And I'm giving you 3 minutes of your day back. So thank you all. I really appreciate your time today, and to all our presenters and to our committee members.